morning, Willem. It's great to have you here in Braunschweig at CED Nord, and we just heard your talk. And I would want you to ask you if you again tell us what are your main points.
Yeah.
For, let's start with Crohn's disease. What are your main points in surgery in Crohn's disease?
Yeah. Well, I think in Crohn's disease, for segmental disease, limited segmental disease, we have now accumulating evidence that even in uncomplicated disease, early surgery is beneficial for the patient, reducing subsequent surgeries and also the need for medication. We have the LYRIC trial, we have a big study from Colombel, we have the Coriol study looking at that, and also patients who have higher risk of recurrence, you could consider scoping them at 6 months, and then if they have recurrence, start them with therapy instead of giving them prophylactic therapy. So I think that's evolving evidence and knowledge, and I think gastroenterologists should consider this. With respect to surgery, there was a big hype whether we should take the mesentery out in resection, for instance, ileocolonic resection, thinking that the mesentery could be the driver of the disease. But we just showed in a nice trial in Italy and the Netherlands that it's all a hype. We just can leave the mesentery. It's probably what happens there is a protective effect of the disease in the bowel. So I think those are the two most important take-homes of the talk.
In the LYRIC trial, it's about half of the patients who really profit from the operation, isn't it like that? But we don't have a marker yet. We don't know which are the 50%.
Yeah.
That's the real problem.
That's the real problem.
Yeah.
And if you start with medication, of course, then in the end, half need surgery, but the other half, they are still on the medication. If you do upfront surgery, then after the surgery, if you do a, let's say, endoscopy guided reinitiation of medical therapy, half of the patients will never have medical therapy anymore, so which is beneficial.
And nowadays, surgery, laparoscopic surgery, in that situation is a very safe. It's a safe procedure. In 99%, nothing happens. It's not a problem.
It's of course it's an operation with some morbidity, but the morbidity rates are low, and it's also because of the fact that surgeons are more centralizing surgery for IBD. So it's not only the proficiency, but also that more units are specializing in a specific field, improving the results also for surgery. Yeah.
What are your points for ulcerative colitis?
Ulcerative colitis, I think the points are that you are able to prevent that we need to do an emergency colectomy if patients are admitted with an exacerbation because you have better drugs. But in the end, the colectomy rates are still high, so we have to realize that it's difficult in an outpatient setting to counsel the patient and to decide at which point the patient should go for surgery. There's a risk of cancer in these patients if they have long-standing ulcerative colitis. Surveillance is difficult if the colon is inflamed. So these are all points that will make treatment of these patients more difficult. Because we don't want to colectomize everyone, of course, but some they really need it and improve quality of life, and others to prevent cancer to happen. One of the hypes in ulcerative colitis is the appendicectomy. We have now accumulating evidence that appendicectomy changes the natural history of the ulcerative colitis. We have seen it in mild to moderate ulcerative colitis and also moderate to severe, that appendicectomy is able to provide a complete endoscopic remission in 1 out of 4 patients on a long run. How it works, we don't know, but it seems to work. And it should be, maybe if we have more official publications, should be considered to put it in the guidelines that it's a valid option to start maybe with an appendicectomy in these patients.
Great. Well, thank you very much.
You're welcome.
for the interview.
And thanks for having me.
Nice to have you. Thank you.